The Autism Research Institute relies on the generosity of donors like you to make this webcast possible. If you enjoy this presentation, please consider making a donation. Thank you.
Now, before we get started, I'd like to introduce our speaker. Dr. Lauren Moskowitz teaches at St. John's University as an assistant professor of psychology. She completed her internship at NYU Child Study Center and Bellevue Hospital and her postdoctoral fellowship at NYU Child Study Center. Her research focuses on behavioral assessment and intervention for children with autism spectrum disorders and other developmental disabilities in naturalistic contexts, intervention for parents of children with ASD and DD, and cognitive behavioral therapy with children and adolescents. These webinars are made possible through generous donor support. If you'd like to contribute, please visit our website at autism.com. And now we are going to start answering these questions. Dr. Moskowitz, are you there?
Hi, yeah, I'm here. Thanks so much, Denise, for that intro.
Okay, great. Well, I received quite a few questions in advance, so I'm going to start with those, and then people can start typing their questions as well in the question section. This person is asking about how to assess and sort out pain-related issues from strictly behavioral issues, or if those things are so intertwined that you don't need to separate them.
Right. That's a really, really excellent question. Can I give a long answer to that, just because I think also it'll probably help set the stage for maybe some other questions.
Yes.
Those of you who've seen maybe my longer webinar on how to assess and treat challenging behavior know that you have to do a functional assessment basically, which means try to figure out what the function or purpose of self-injury or any other kind of challenging behavior is, and then try to design your treatment based on that, right? So we do know that self-injury, as well as other challenging behaviors like aggression, can serve the purpose of, for example, getting attention from parents or teachers or peers. The self-injury can serve the purpose of escaping something you don't want to do. We call that escape demand. Like if you give someone homework or an academic task or a chore and they engage in self-injury, they end up usually escaping the thing they have to do or delaying it at least. Another function is what we call tangible, meaning that they can engage in the self-injury to get something like a food or an activity or a toy, something they want. And then the last kind of main function or purpose is what we call automatic reinforcement. That includes a lot of the sensory stuff, right? Like you can engage in self-injury to maybe increase your levels of arousal or decrease your levels of arousal in some way. And also in that category would be reducing pain, right? Or maybe, again, if you feel nothing, maybe trying to make yourself feel something. So basically all of those internal sorts of things, right? So again, how do you know if it is pain? Often it can be a combination of many of those things. I think that's a great question. Sometimes it could just be pain, right? The main way we do that, first of all, is we try to conduct, like I said, a functional assessment to figure out if it serves one or more of those functions, right? Sometimes, again, when you kind of look at the antecedents, behaviors, or consequences, you can tell pretty quickly that, oh, okay, every time that person engages in self-injury, they escape something they don't want to do, or almost every time they get some sort of attention. So often, again, it can be clear it's those. When we conduct something called a functional analysis, sometimes you don't see a pattern across different conditions, that the person seems to be engaging in self-injury all over the place, right? Or in a really unpredictable fashion where you really can't figure out the pattern. Or they might tend to do it more when they're alone, for example, right? That really kind of clues you into the fact that it might very well likely be some sort of sensory or automatic function, such as reducing pain, right? So if the individual is engaging in self-injury when they're all by themselves or in the corner of the room, you're not even there. You're not giving them attention in response to it. No one's giving any demands or taking any demands away. They're just doing it by themselves, without any other kind of social antecedents or consequences. That's what gives you a sense that there's something internal going on, right? And pain could be one of those things. So just sort of as an example, my lead advisor always gives the example, this was back in the 70s, where they were conducting a lot of functional behavior assessments with this individual who was banging his head into a wall, and they could not figure out what the function is. There were no patterns. They couldn't figure out why the individual was doing this. And after many, many months, I think, they finally started assessing him for migraines, and it became very clear that, again, he was banging his head into the wall to reduce the pain, which, you know, I know when I have a really bad headache, it's like you almost want to kind of make something else hurt to just numb that pain. So it makes a lot of sense why the individual is doing that. So sometimes in cases like that, the function or the purpose can just be to reduce pain. But to answer that person's question, you're right, sometimes it's hard to tease apart, and sometimes it could be both, right? And to give you an example of instances in which it's both, quote, behavioral as well as related to pain, a good example of that would be another study also conducted by my lead advisor on menstrual pain, right, on women with autism who were experiencing menstrual pain. And what they found was the women's self-injury and aggression was really not that high if you just gave them a demand, like, you know, brush your teeth or make your bed or something like that. And it wasn't that high when they were just experiencing menstrual pain, right? But it was the combination of those two things. When they were experiencing menses and a demand was placed on them, like make your bed or, you know, fold the laundry, that's when they engaged in self-injury or problem behavior to escape that. And that makes sense. You know, if you think about yourself, or I know that's true for me, you know, if I'm in pain or I'm really tired, then any demand that would normally maybe be okay on another day is just going to be awful, right? Like I had a headache all day yesterday, and any demands that, you know, if my husband said, hey, could you wash the dishes? You know, on a normal day, I'd be fine with that. But when you have a headache or you're in pain, everything just seems so much worse, and you want to escape so much more, right? So sometimes it really is the interaction of those two factors, what we would call setting events like pain or fatigue, the combination of that plus something in the environment, like a task demand, like do your homework, right? So that's a kind of really long answer to that question, but I think hopefully the message is that sometimes it can just be behavioral, right? Meaning to get attention, to escape a demand. Sometimes it could just be pain, like to reduce pain, but often it really is a combination of those factors. Did that answer the question, I hope, in a long-winded fashion?
Yes. The next question is about replacement behaviors. This person is asking what some replacement behaviors could be utilized for an adult that gets angry and hits himself. And then they've got a couple follow-up questions as well. So I'll let you start with that.
Okay, so what replacement, I hear a little bit of an echo when you're talking, so I just want to make sure I heard it okay. So the question is, what replacement behavior can you teach to an adult who hits himself? That was the question?
Yes.
Okay, so let me sort of just go back to my previous answer for a second. The first thing you have to do before you figure out what replacement behavior to teach is figure out what function hitting his head is serving, hitting himself is serving, right? So, for example, and you know, again, this is really key because we know again that whatever replacement behavior you teach, it's going to be a lot more effective if it's in some way related to the function or purpose of that individual self-injury, what he's getting out of it, right? One of the main studies back in '94 they did of self-injury, Brian Awada, they showed that a lot of people engaged in self-injury, like hitting themselves, right, to escape from task demands. I think that was over 30% of people with disabilities were engaging in self-injurious behavior to escape from task demands. I think about a quarter of them were engaging in self-injury to get attention or get access to food or toys or something like that. And then about a quarter of the cases, they were engaging in self-injury for sensory reasons, right? So first you'd have to figure that part out, right? Why is he hitting himself? Is it for one or more of those reasons? And then the replacement behavior you teach would be linked to that. So for example, again, in a study in '85 that Ted Carr and Mark Duran conducted on functional communication training, meaning where the replacement behavior you're teaching is communication, again, it had to be linked to the function. So if the kids were engaging, and again, this is true for kids or adults, but if the individual is engaging in problem behavior, for example, to get attention from, in this case it was kids, so in this case it was the teacher, the replacement behavior they taught the kids was, am I doing good work? Or, hey, look what I did, right? As a good way, basically, to get the teacher's attention instead of injuring themselves or being aggressive, right? Whereas for other kids, when the function of their behavior was to escape the task, like, you know, maybe the schoolwork was too difficult for them, they taught those kids to say, I need help, or I don't understand, or, can you help me, something to that effect, right? So again, what you teach this individual, this adult who is hitting himself, it would be based on knowing what the function is. If he's needing, perhaps he's hitting himself because then he gets out of tasks that are difficult for him, or he gets help with something, right? So again, the replacement behavior you teach him could be something like, can you help me? I need help. I don't understand. Or just, I want to break, something to that effect. If he's doing it in some way to get your attention as a parent or staff's attention, again, you could teach him to say, hey, I want to play a card game, or something, again, either verbally or with sign language or with an augmentative communication device. You could teach him some form of communication that helps him to get that need met. And if the function, let's say, is automatic, meaning sensory or internal, you can also figure out what kind of sensory function is it serving and how could we replace that. So, for example, a study, Catherine Piazza, I think in 2000, they found, they were able to reduce the rate of kids who were, I think, biting their hand or mouthing their hands when they gave them access to, like, chewy candies, or I think a massager, something that created sort of a similar sensory experience that the kids were getting from mouthing their hands. And those things that gave them a similar sensory experience were more effective than just other sensory items like a strobe light or music or something. So really figuring out, again, what they are getting out of that behavior, what he is figuring out, what he's getting out of hitting himself, and then figuring out, again, how to replace that with something similar. Does that answer the question?
Yes.
Okay.
So this next question relates to that. It's from the same person. Mm-hmm. And they're saying, if an adult previously hit himself in the head and then verbally tells you he will resume hitting himself if he doesn't get what he wants, how could that be handled?
I see. Okay. Well, what is it he wants, I guess, is the question. It's again, like, I think the first piece is figuring out what is it he wants. Is it attention he's trying to get? Is it food or specific toys he's trying to get? Is it to get out of doing something? I don't know if the person can respond to that.
It doesn't say what it is that the person wants. So I may get a follow-up on that. But yes, and then the follow-up.
So most likely there's probably particular patterns again, right? So let's suppose, again, it's always about getting the iPad at a particular time. I'm just making this up. Or watching TV, right? If you know that that's the pattern, they engage in self-injury, like you said, and I'm not going to stop hitting myself until you give me this thing, right? So the first thing you have to do, again, is conduct this functional assessment to figure out what are these patterns. When are the times that individual is going to do that, right? Because you want to head that off before it happens. Right before you know, okay, now's about the time he's probably going to hit himself so that I give him, or like, let's say we're in the grocery store. Now's the time he usually hits himself because then he's not going to stop until I buy him candy on the checkout aisle, right? That's when you would want to beforehand say, remember, if you hit yourself, I'm not going to get you candy. But if you just ask me, can I have candy, then I will get you that candy, right? So you're trying to prompt that replacement behavior before they actually engage in self-injury, right? And I realize you can't give someone what they want forever, right? I get that. Believe me, I 100% get that. But in those initial stages, you are trying to get that individual to do anything other than self-injury. You want them to do the appropriate behavior. So anytime they do something appropriate, instead of the self-injury, like, say, play with me, or, can I get help with that, or can I get that candy? Whatever it is, if they're doing any appropriate behavior to get what they need instead of self-injury, you give it to them every single time, right? Every time. After, let's say, I'm just making up an arbitrary number, let's say 2 weeks, where they have used that appropriate behavior instead of engaging in self-injury, that's when you would want to start fading out that immediate reinforcement a little bit, right? So, for example, let's say you taught the individual to say, I want to break, every single time they didn't want to do something instead of hitting themselves, right? Initially, every single time they say, I want to break, you give them that break, right? So when they're reliably saying, I want to break, instead of hitting themselves for, let's say, 2 weeks straight, then you could start fading out that immediate reinforcement. So when the individual says, I want to break, you could say, okay, do one more math problem, then a break. Next day you could say, okay, do 2 more math problems, then we'll give you a break. Next day, okay, do 3 more math problems, then we'll give you a break. Does that make sense? So you're not forever giving that individual what they want immediately as soon as they ask for it. But certainly at the beginning, you are really trying to give them what they want in response to appropriate behavior instead of the self-injury, and not give them what they want in response to the self-injury, which again, I get is the most difficult part. As a parent, like that is, I have a hard time, not giving even when my child's tantruming, I get that. But certainly self-injury is the hardest thing to withstand. But I think that's why a lot of it rests on trying to figure out what those patterns are and try to intervene before they're engaging with self-injury by prompting them to engage in that appropriate placement behavior. Because usually there's probably pretty clear patterns. You probably know the things that are most likely to trigger self-injury in your kid. And I think it's just exhausting, so it's hard to sometimes see those patterns when you're in it on a day-to-day basis. So I encourage you to step back for a minute, or even take data just for 3 days and say, okay, what were the things that provoked a self-injury? When I turned off the TV, or when I told him it was time to get out of the bath, or when I told him it was time to make his bed, whatever it is, right? Looking at what those patterns are and then trying to head that off beforehand.
Okay, so moving into a different age group now, we've got a question about a 5-year-old boy. This person says, the child does not hurt himself, but he hurts peers. This happens only at school. Teachers insist on treating with social stories and instruction, but he does know that the behavior is not allowed. The teachers think he's aggressive, but I think he really wants to hurt the other children, even though he knows they will be hurt.
Yeah. So the same thing applies. All the same stuff I've been saying basically applies for aggression, the same way as self-injury, right? And that the first thing you have to do again is really just figure out what the purpose or function of that kid's hurting his peers is. I highly doubt, I can't say this definitively without an assessment, obviously, but I really, really highly doubt this 5-year-old boy just enjoys hurting other people, right? He's hurting other kids in school because it works for him. It's working, right? He's getting some need met. He's getting something out of that, right? Again, I don't know what it is without seeing it, but some of the common scenarios I see are kids hit other kids in school because every time they hit them, the kid gives them whatever toy they're playing with, right? That's a really common scenario I see with 5-year-olds all the time. They hit another kid, the kid, gives them the truck and runs away crying or something to that effect, right? So it could very well be that this 5-year-old gets things he wants every time or almost every time he hits other kids, right? Or it could be that he hits other kids, they hit him back. I'm thinking of a lot of the 5-year-olds with autism and developmental disabilities I've worked with. They hit other kids, the other kids hit them back or yell or scream or tell the teacher, then the teacher comes over and lectures them, right? Often a kid with autism or developmental disabilities doesn't really know how to interact with his peers. He doesn't know how to get attention from his peers. So the most effective way this kid has is hitting them or hurting them in some way because it gets some sort of reaction, right? He doesn't know how else to interact with them. It's almost like sometimes it can almost be a game. Like, that old kind of cliche in old movies where, a little boy will pull a girl's hair that he has a crush on. The little girl will be like, cry and scream and yell. And you might wonder, well, why would he do that if he likes her, right? But sometimes getting that reaction from kids, again, is very, very reinforcing. And other kids really react a lot when you hurt them. And most likely the teacher's probably reacting a lot too. So another reason it could be doing it is to get attention, right? But again, another common reason is to escape something. Often I see kids hit their peers in school because they get out of doing something they don't want to do. Like, let's say they don't want to wait in line with the other kids, right? Let's say the teacher's like, okay, everyone line up. The kid lines up. He hits his peers. The kids all start screaming. The teacher's like, all right, that's it. Get out of line. Go sit down over there. That might be exactly what the kid wants, right? I see that time and time again where the kid gets out of activities that are difficult for them, escapes things they don't want to do when they hit other kids, right? So again, it could really be any of those reasons. I highly, highly doubt he's doing it because he enjoys hurting other kids. He's doing it because it's working for him. He's getting something he needs from that. And to figure out what that is, you'd have to just, again, watch a few times. Technically, the way you're supposed to do it is do what's called a functional analysis, where you put a kid in each condition, giving them attention, letting them escape, giving them a tangible. I realize that's really hard for parents and teachers to do, especially in classroom environments. So another thing you could do is just what's called take ABC data. Look at the antecedent, the thing that comes right before the kid is hitting his peers, right? Is it that the teacher says, okay, everyone line up, or is it they give him some sort of demand, or is it that the kids are playing with some toy he wants? What is the thing that occurs usually right before he hits other kids? And then what's the thing that happens right after, right? If the thing that happens right after, it's the kids scream and yell and the teacher lectures the kid's probably doing it for attention, right? If the thing that happens right after is, you know, the teacher's like lets him out of something or says, okay, go sit over there, all right, you don't have to wait in line, or okay, you don't have to sit in circle time. I see that a lot. I'm thinking of one of my kids who would always hit his peers when they were sitting in circle time or morning meeting time, and the teacher would always send the kid to sit out of the circle, obviously, because he was hitting his peers. So this worked really well for this kid because he didn't want to be in circle time, right? So again, if you see that's always the consequence after a few days of taking DETA, that gives you a sense that the purpose of these kids hitting other kids is to escape. And then similarly, if almost every time the kid's hitting other kids, they give him something, like they give him a truck or a toy or a Lego or whatever it is, it gives you a pretty good sense that he's doing it to get things or stuff from other kids. And it could be some combination of all of those things, right? So again, what you would do, the intervention you would choose, would be based on knowing that first.
Right, this is a tricky one. This parent is asking, her son is older and he's very frustrated because he wants something that's impossible to have. He's asking a movie producer not to make a sequel to a movie. He has an internal antecedent that he's thinking about obsessively, and he's very concerned that the producer will not respond to his request. So how do you deal with something like that when you're talking about self-harm?
Yes, that is super common in individuals with autism, absolutely, because they often have what we call obsessive or circumscribed interests or perseverative interests that are really obsessive, as we've said, and can be often unfulfillable, like you said, in some way. Absolutely. So there's a bunch of different things I would say. First off, the same rule about figuring out the function first still applies, right? Because, you know, I think you're assuming you know what the function is, that it's really about getting the movie producer to not make that sequel. But that might not really be the function. And I would argue that's not the function because, like you said, that's not happening, right? He's not actually talking to the movie producer, right? If I had to guess what was going on, because from thinking of all the kids and adults I've worked with, again, this talking about this perseverative topic is very reinforcing for them. Like often they like talking about the subject matter, but often it gets a big reaction from adults, right? Or from other people around them. So you know how, like for example, I'm thinking of again my daughter who's 3 right now. You know, anytime I read her a book, she always asks basically the same questions about that book, and I always, you know, give her the same answer. Anytime we listen to Circle of Life, she's always like, "Who's holding baby Simba?" You know, she knows the answer to these questions. It's just a matter of routine and consistency and predictability. Individuals with autism, a lot of the times they do talk about those same topics over and over and over again, because it is, again, consistable and predictable, right? But often they don't necessarily have the language or social abilities to really be able to have a conversation about something else. So often the function of this kind of behavior is to sort of have a conversation or social interaction, right? So for him to say to his mom or his dad or his staff member, I don't know who the person is, for this individual, he's probably saying, you know, oh, I don't want them to make a sequel to this movie. I want to call the movie producer and tell them. And most likely, you know, the parent or teacher or whoever else is responding to this, and they're probably having an extended interaction about this in some way. Or even if it's not extended interaction, maybe they just always give the same predictable response. Like, well, you know we can't call the movie producer, right? Well, you know we can't do that. He's going to make a sequel, right? But whatever it is, it's really kind of the same as my daughter saying, "Who's holding baby Simba?" and I'm saying Mufasa each time. It's that routine. It's that kind of predictable, consistent routine, right? So often it can serve that function of, again, just sort of obtaining predictability or consistency, or it can serve the function, we know echolalia, perseverative speech in general, can serve the function of getting attention, helping individuals to, again, have some sort of social interaction. So that could be what's going on here. It could not be as much about really getting the movie producer not to produce the sequel as it is about this individual may not know what else to talk about, right? So knowing that gives you a bunch of different things you can do, right? Rather than probably what you're trying to do right now, I would imagine, is get the individual to stop talking about that, because it's probably annoying and frustrating and all-encompassing. So what I would recommend is to try to bring it under what we call stimulus control in some way. Letting it happen, for example, rather than trying to stop it, but in a specific time or place, right? So to give you an example of what I mean, a 25-year-old with intellectual disability, he was always asking his mom all day long to spell different words for him. As you can imagine, it was exhausting for Mom all day long. She would sometimes spell words, but then usually get frustrated and say, no, I'm not spelling any more words for you. But it ended up being, again, the vast majority of their social interaction was just about spelling these words, right? So then rather than say, okay, we're never going to spell words for you or spell words all day long, what we did is we said, okay, 8 to 8:30 a.m. every morning is spelling time, where Mom's going to spell as many words for you as you want, right, but not the rest of the day, right? So in the rest of the day, whenever he would ask to spell a word, Mom would just point to his book, his notebook, because he could write the word in there if he wanted, and then would not spell them for him until the next morning. The first day or two of this, he obviously was not thrilled with this and was kind of tantruming in the afternoon about this, but got with the program pretty quickly, right? And it was a lot easier than trying to just cut this out completely of his life. Because again, it is giving him some sort of sensory need in some way, right? So again, you know, that was an example of we were able to kind of relegate it to just 8 to 8:30 in the morning. There's another example, another girl with autism I work with who was 19, constantly tried to talk to her mom about seizures all the time, which is again a similar sort of odd interest, sort of like getting a movie producer to not produce a sequel. The kid just always wanted to ask about people having seizures and have the mom tell her about seizures. So obviously the mom was really concerned about this and would just say, no, I'm not talking to you about seizures, right? So instead of just saying constantly all day long, you know, 500 times, I'm not going to talk to you about seizures, what we did is use that interest to our advantage. So this girl was refusing to attend school. So what we said is, okay, if you get ready for school and get in the car on the way to school, Mom will talk to you about seizures the whole way to school, but not throughout the rest of the day, just then. And kids and adults do get that pretty quickly, that here's the time of day we can talk about movie producers. It can be a special time, you know, over dinner, we're going to talk about this movie, or we can even pretend to write a letter or call this person and tell them that you don't want to produce this, right? But then the rest of the day, I'm going to ignore it when you talk about that, right? Or point to the sign that says, you know, you could have a sign like what we did with the individual with spelling time is we had a sign that said spelling time, not spelling time. And when it was spelling time with a green light and a red light, and when it was spelling time, you know, we would say it's spelling time, and when it was not spelling time, we would have the red sign present. So you could do something similar with talking about, you know, the movie producer and the sequel. Okay?
Okay, I've gotten a couple of questions about taking ABC data. So one person's asking about how you do that for social and other behaviors, and then this expands on it a little more. This person's asking, I have a 5-year-old who will scream, kick, hit, and bite. It's never for the same reason, as far as we can tell. He only hits adults. The ABC data seems very inconsistent, and the incidents. Yeah. And when we try to redirect to calm, it seems to make it worse. Parents have seen 4 therapists in more than 3 years, and they can't pinpoint it.
That's hard. So times when, so I wish I could ask this person a question. So times ABC data is great and very helpful, but we do know, you know, it's not always correct. It's not always, you know, you can't always figure it out. That's why often when we can't figure out what ABC data means, it's helpful to get what's called a functional analysis from a board-certified behavior analyst at BCBA. And again, a functional analysis is that actual experiment where they put them in several different conditions, like I said, an attention condition, an escape condition, a tangible condition, and an alone condition. And again, if you see that the individual's behavior is really the same across all those conditions, or that they're doing it more in the alone condition, like meaning they're doing it when they're just by themselves, that's what lets you really know for sure that you're right. It's not social. It's not that they're doing it to get attention. It's not that they're doing it to escape something. They're doing it for some internal reason, right? That's when, or when it's undifferentiated, what we call, you know, across those different conditions. That's what really lets you know that probably something like pain or fatigue or some sort of internal discomfort is really what's going on. Presumably, hopefully, this individual got a complete medical workup, but you know, there could be something like GI problems. There could be something like, you know, irritable bowel syndrome or something like migraines, something that, again, is causing it, which is why the individual could be doing that seemingly out of nowhere. Or like I said, even if not pain, sometimes individuals could be engaging in self-injury to just increase or decrease their level of arousal, right? So, for example, I bite my nails. I'm, you know, full disclosure here. Probably something I could stop if I tried really hard. I just don't. I'm just being perfectly honest, I'm not super motivated enough. Even though my nails do look disgusting, it doesn't really impact my life in other ways. But to give you an example, what I mean by increase or decrease arousal, you know, if I'm stuck in traffic and I'm really bored, you know, and I'm kind of falling asleep, I bite my nails. In that case, the function is to increase my level of arousal, to keep myself awake, to stimulate myself, right? Whereas in other situations where I might be a little nervous or anxious, I'm also biting my nails. And in those situations, the function is to calm myself down, right, or to reduce or decrease my level of arousal. So part of, if I really wanted to change this behavior, part of what I would have to do is not only reinforce myself for not biting my nails, but I would also have to come up with a replacement behavior, something that helps me to, again, serve that same kind of sensory function, like maybe chewing gum in the car when I'm bored to increase my level of arousal, or something that helps me to decrease my level of arousal when I'm anxious, okay? So similarly to your child, again, if the ABC data is showing no pattern, my guess is you really need to go to a BCBA and try to get a more thorough functional analysis done. But also I would suggest a complete medical workup, because again, it sounds like there really could be something sensory or internal or automatic going on. That said, I was telling you guys about the study by Brian Iwata where they really looked at the function of self-injury, and I know I said this, but I just want to repeat it. Usually when I first talk to parents, the first thing they tell me is it's sensory or internal. I think that's the first thing everyone usually thinks, because it really is hard to see patterns. But when they actually did a functional analysis, they really found only a quarter of the cases were sensory, right? The vast majority were actually to escape from demand. Then I think the second largest case after that, proportion of cases after that, was to get attention or to get tangible access to food or materials. So I think the moral of the story is it can be hard to see patterns. It can be hard to think that it's anything in the environment that it's contributing to it. So I think often we might jump to the conclusion that it is something sensory or internal when it may not actually be. And just, again, thinking of my own life and how chaotic and overwhelming it can feel when you're with your kid, it can be really hard to see those patterns, right? Maybe it can help to videotape it even and watch it later to look for ABC patterns, or maybe, for example, my husband gets less emotional, I know, certainly, when my daughter's tantruming or upset than I do. So it might be helpful to have, if one of you, either you or a spouse or a grandparent or an aide or someone is a little bit maybe less emotional in those instances when the self-injury or problem behavior is occurring, it might help to have them take some ABC data, and then you look at the patterns later on. Because it's really, really hard to see patterns and to take data when you're in a meltdown. It really is. It's really hard to see it clearly and to be an unbiased observer and be able to see those patterns. So.
All right, that's great. That's really good information about data taking. And I think you actually answered her question, because her next question was about who would perform a functional behavioral analysis, which would be a BCBA. So as far as getting a medical...
Yeah, and I just want to expand on that. You can do, the ABC data often people do themselves, like parents. Again, Mark Duran has, and Mimi Heineman has a wonderful book for parents on positive behavior support, and Mark Duran and Mimi Heineman have a manual, a treatment manual. Why am I blanking on the title right now? Hold on, let me look it on my office shelf. Helping parents, there we go, helping parents with challenging children. And so it gives you a lot of great ABC data sheets in there, but you can also Google them online and find a lot. The Kansas Institute for Positive Behavior Support has a lot of great resources. KIPBS, where they actually have a lot of free tools, like a modified version of the functional assessment interview, where you can interview not just yourself, because again, I know sometimes I just can't see the patterns when I'm in it, really. I mean, I see it a lot more with my clients than I do with my own child, to be honest. It's hard. So you can interview your husband or your kid's teacher or the kid's grandparent or whoever else, or your wife, you know, to get a sense of what they see as the consequences and antecedents to that kid's behavior. And so again, it gives you a template, it's called the functional assessment interview, the FAI. You can just Google functional assessment interview, and I think KIPBS, the Kansas Institute for Positive Behavior Support, can give you a free version of that. They also give you free ABC data sheets on there. Laura Riffle's website, Dr. Laura Riffle, behaviordoctor.org, also gives a lot of great tools to be able to conduct a functional behavior assessment on your own, with, again, ABC data sheets and interviews and all that sort of stuff. But again, you know, sometimes, you know, I think all this stuff can be pretty accurate. We know interviews and ABC data can be accurate, but they're not always. And so sometimes when we're not really sure of what the patterns are based on those, it can be really, really helpful to get an actual functional analysis, like which is an experiment conducted by a board-certified behavior analyst, a BCBA.
Okay, great. The next one, we're going to switch back. This is a person asking about replacement behaviors again. They're asking about teaching replacement behavior with somebody who is nonverbal, and how that can be taught, especially if it's for frustration or demand escape.
Absolutely, right. So I will say my background is with kids who are nonverbal, so that's actually probably more of my area of expertise even than people who are verbal. And you would teach it in the exact same way, except what you're doing is maybe not speech. It's you're teaching maybe sign language, or maybe you're teaching communication with an augmentative communication device, right? Like a, you know, like a, I was going to say a chat PC or a Dynavox, but I don't even know. People might use the iPad more nowadays. I don't even know what people use with technology, but I guess probably more people might use the iPad. But you could have things like Proloquo to Go, or on there where the kid actually, you teach a kid to, again, point to a picture that will then say the word, right? So if, you know, same way if you were teaching a kid to ask, let's say, again, a kid's engaging in self-injury or problem behavior to escape a task that's difficult for them. You could teach them to touch the picture on their iPad or chat PC that says break, and then you'll hear, I want a break, and then you could give them a break, right? Or you could teach them to touch the picture that says help, and it will say, I want help, you know, and then you could give the individual help. Other ways to do it, again, you know, so I will emphasize, you know, the way you teach this is through prompting first, right? So let me just, maybe I think this example could actually help illustrate, but I'm thinking of a 9-year-old with autism I worked with who, in class, whenever another kid would cry, I guess the sound of crying was really aversive to this boy with autism, so he would scratch the other kids or bite them or hit them in some way, right? And what usually happened in response to this is the teacher would take this kid to the break room, right? So hopefully just knowing that little bit of information could let you know or give you the idea that it's pretty clear that the function of this kid's behavior was to escape the classroom, to escape the crying, to get out of that situation, right? So again, it was, you know, what the teachers were doing was just maintaining this behavior, right? Because every time this kid aggressed towards his peers, he got to leave the classroom and go to the break area, right, which was great for him, right? That was working out really well for him. So instead what we wanted to do is teach him, you know, as soon as another kid cries, as soon as another kid starts crying, that's when you want to prompt him to, and he was not completely nonverbal, but very minimally verbal. That's exactly when you want to prompt him to point to the picture of, I want to break, right? So it's hard to practice this in the classroom at the beginning. So what we first did was just practiced it like in my office, right, where I just played him first just YouTube audio videos of kids crying, right, other kids crying, and before I would even start it, I handed him all these different break cards, and I said, as soon as someone cries and you want to break, hand me the break card, and then you get to leave the room. And I knew he didn't necessarily understand that, so as soon as I started playing the video of a kid crying, like after a millisecond, I took his hand, I put it on the break card, and I prompted him to hand it to me. And then I said, oh, you want a break? And then I just, you know, let him out of the room and turned off the crying. After only 5 times of me doing that, he handed me the break card on his own as soon as I started playing the crying, right? Then we escalated to like louder crying to videos of kids crying on YouTube. Then we started practicing with me crying, with his mom crying, with his sibling crying, videos of the actual kids in class crying, and then we really took it into class. So that as soon as a kid started crying in class, we would prompt him right away to say, I want a break, right? And point to his break card and immediately give him a break, okay? So, because I think the biggest reason that people say, oh, this stuff doesn't work is because teachers or parents think that the kids are just going to do it on their own, right? They're not going to do it on their own right away. You're going to need to prompt them at the beginning. But they will figure it out pretty quickly and start doing it on their own, right? So initially, again, like I said, every single time they ask for a break, you give them a break card. I mean, you let them have a break. Over time, you could cut down on the number of break cards you're giving them, or cut down on the number of opportunities for breaks, or do what I said before, which is to say, for example, you asked for a break. Okay, first do this, then you get a break. Okay, 2 more minutes, then you get a break. Next day, okay, 3 more minutes, then you get a break. Or, 1 more math problem, then you get a break. Next day, 2 more math problems, then you get a break. So you are, over time, going to fade out how immediately you give them breaks or the number of breaks they're getting. So you're not going to be giving them a million breaks for the rest of their lives. But certainly at the beginning, your whole goal is to just encourage functional communication instead of the aggression or self-injury. That's your main goal at the beginning. Does that make sense? So hopefully that helps explain how you would do it with a nonverbal child. You're doing it the same way, except instead of prompting them to say something, you're prompting them to point to a picture that says something, or hand you a picture, hand you a card that says break, or, play with me or whatever, or sign it. Does that answer that, I hope? Okay.
Yes, it was great. The next question, I think you'll have some good answers for this one. It's about using Extinction. So this person has a 6-year-old who has done a lot of head banging, and at this point, she's being advised to extinct it, so to ignore it, but she's concerned about it. So she's wondering about when it's appropriate to use Extinction, and I don't know if you can answer that or not. But
that is an excellent question. And I'll be honest, Extinction is the hardest thing in the world for any parents I've ever worked with, any teachers, and now for myself as a parent. Extinction is my downfall as a parent. I think I'm pretty good on all the positive reinforcement and prompting and antecedent strategies, but it is so hard to watch your child, especially if it's hurting themselves. I understand, and I don't know as a parent that I could just simply ignore that or let them do it. So there's a few things I want to say in response to that. First of all, you would only want to, quote, ignore it or not pay attention to it if the function is to gain attention. And I do think that sometimes people jump to the conclusion. A lot of people think extinction is the same thing as ignoring. So often the response is always just ignore it, okay? But there's ways to do more gradual or graduated forms of extinction. And you don't necessarily have to, there's a difference between ignoring the child and ignoring the behavior, right? So that's one thing I do want to point out. So for example, one time, a child I was working with, and we were having a conversation. In the middle of this conversation, he just pulled down his pants and said, "Take my temperature," right? So I didn't ignore him in that I left the room or turned around or stopped talking, because that actually would have been a response, right? So what I did was just keep talking to him and pretend like I didn't even notice he did that, right? And he never did it again. Whereas with other people, he did that because it got some sort of reaction. So true extinction, he was having no effect on his environment, in other words, right? So that was an example in which you can ignore a behavior without necessarily ignoring a child. Now, obviously, with self-injury, like I said, it's more challenging because, I don't know that I would just obviously let my child be bashing their head against the wall. I also think it depends how severe it is, I will say. With some more mild forms, like if they just slap themselves, for kids who slap themselves or something where it's not actually making them bleed or leaving bruises, I think I have, when it's attention maintained, ignored that. But keep in mind, hopefully you're doing the other stuff in terms of that you're trying to prompt functional communication before that happens or prevent it in other ways before it happens, right? So that you're not, extinction should never be the main tool in your toolkit, right? And you should certainly never be doing it alone. I get so upset when one of my grad students their whole behavioral plan will just be extinction. Like, that's never something you should just be doing on its own. Extinction should be kind of your last resort when the behavior happens. but ideally you should be doing everything in your power to prevent it from happening. I understand that you can't always prevent it from happening. I get that. So in those times when it is happening, I think your goal could be, how can you could still block the self-injury, but trying to attend to it as little as possible, or doing it in a more neutral fashion, right? So, you could still, again, let's say the individual is, I'm trying to think biting their hand, right? You could give them an alternative command that directs their hand to something else, or put their hand on something else, or just walk and hold their hand, somehow do something that redirects that, but without saying, don't bite your hand, right? Because often the attention that's maintaining self-injury can often be verbal. So at least you can try to block it non-verbally or redirect it non-verbally without giving verbal attention to it and saying, don't bite your hand or don't hit yourself, right? So I think there, again, are ways to block it without doing that. That said, I know this is, a long, complicated answer. Again, I think there's a debate about to what extent extinction is necessary. Certainly the research by Brian Awada and by others do show that when you use functional communication or any procedure with extinction, it's more effective than if you don't have extinction. That said, there was a study by Alphins and Vollmer in 2010 that showed that you may not necessarily need total extinction, that you just need to provide more reinforcement for the positive behavior or for the replacement behavior than you do for the self-injury or the problem behavior. So what that means is kind of think about it like, I wish I had a visual here, but think about it like a scale, like a scale, like the justice person is holding a scale, right? So think about tipping the balance, right? The individual is going to do whatever gets him more reinforcement, right? So extinction means no reinforcement for problem behavior, none, right? You may not have to have zero reinforcement for problem behavior. You may be able to attend to it in some way. However, your goal is to make sure you're still providing more reinforcement for the opposite of that self-injury, for whatever behavior is incompatible with that. So, for example, let's say they're biting themselves. So you just want to be providing more reinforcement for some behavior that's incompatible with that, like something they can do without that would make them not bite themselves, like whether it was chewing gum or drawing with their hands or something else, right? Or you would be providing more reinforcement for, again, using appropriate communication to get what they need instead of biting themselves. In general, you just want to make sure that you're providing more reinforcement for the positive behaviors than for whatever the problem behavior is. You might not need total extinction to reduce that. And then finally, the last kind of point I want to make is that, again, I do just want to show this enough that, again, hopefully you may not need to resort to extinction per se. I'm thinking of a really old study by my late advisor in '76 where they found that these two individuals engaged in a lot more self-injury during academic tasks, I think, right? Because whenever they engaged in self-injury, the academic tasks terminated. They didn't have to do it anymore. They were ended, right? So what they did in this study is they were able to reduce the individual self-injury by just including these non-demand periods. I think reading entertaining stories to the individual during these demand conditions, right? Does that make sense? So again, you can do a lot of things that I think are going to reduce the self-injury so that it's less of so that extinction is less of a concern. I think too often people are trying to rely too much on extinction, but there's a lot of things you can do to try to kind of head that off. Again, I recognize not all the time. I hope that answers your question a little bit.
Right, and one step beyond extinction, I've gotten a couple of questions about when it is appropriate to use restraint to protect other children or if it ever is appropriate.
Right. Okay, well, restraint, so, a book I'd really recommend is a book called Communication-Based Intervention for Problem Behavior. It's by my late advisor, Edward Carr, et al., 1994. It's a fantastic book. I think it's just very user-friendly, very jargon-free, very easy to read. I assign it to my undergrads, actually. But So in there, restraint is listed as one of the crisis management strategies, right? So I think the important thing to realize is crisis management is not the same thing as intervention, right? Often what you're doing during a crisis could make that behavior worse in the long run. So yeah, there are probably times that you need to restrain an individual if it comes to protecting himself or you or someone else. I recognize that there are those times that are necessary. However, the problem is people do that, they restrain the individual, and then they don't do anything else. The crisis is over, and then the same thing happens again, right? So I think the most important thing is you view restraint as a temporary strategy you might use in crisis, but then when the individual is not in crisis, when the individual is not, so again, like the example of like the kid who was going after his peers, right? Like, the kid I was talking about who would attack his peers when they cried, right? Obviously, in that example, you might want to either restrain the kid or at least just pull him off his peers and make sure he's not attacking them. Like, your main goal is safety, right? But that can't be all you do, right? When he's calm, when he's not in crisis, is when we were teaching him how to ask for a break and playing him the videos of crying. So you're heading off of those situations. So again, it's not that you never use restraint, but you recognize that that's not an intervention. All that is crisis management, helping you stay safe when the crisis happens. But all of your efforts should be towards teaching the individual, when they're not in crisis, to prevent those situations from occurring, right? Because I think we all know, think about yourself even when you're super upset, that's not when learning can occur. You're not going to learn anything or be able to process anything anyone's even telling you when you're really upset. So think of a volcano erupting, right? In the middle of that volcano, that's not when you're doing intervention. Your goal is just safety at that point, right? But when the volcano is not happening, when you see the rumbling behaviors, Brenda Smith-Mile calls it the rumbling behaviors, when you see that volcano rumbling, that's when you might want to prompt more appropriate response or do something that somehow can de-escalate the situation, right? And again, when the individual's completely calm, that's when you want to teach them skills, so that they don't need to resort to self-injury or problem behavior, okay?
So one of the recurring themes throughout all of the questions have been about questions about self-injury that you suspect might have a medical or a sensory source. Mm-hmm. So if somebody needs to get that assessed, obviously it's probably a medical doctor, but can you tell me a little bit about that process? Have you ever referred somebody for a medical evaluation, and where would they start?
Yeah, absolutely. I mean, I think often kids go for medical evaluations. They get complete GI workups. They get, tests to make sure there's no migraines or headaches going on. I mean, I think those are some of the most common things. And there's, of course, a whole bunch of procedures you can do to help kids be able to get MRIs. Similar to things I'm talking about. You can help pair the doctor's office with really, really positive, wonderful things. Teach the kid how to give them choices in the doctor's office. Teach them to ask for breaks, give them some control and ownership over it. There's a lot of things you can do to help kids be able to get medical exams. So I think that is certainly one thing I would do. But I think your best way of thinking about it is often globally, because often it's not just pain, but it's the interaction of those things, right? So to kind of give you, I think this is a helpful way to think about it, to remember the study I was talking about in the very beginning that my late advisor did with menstrual pain, right, where the individuals were engaging in self-injury and aggression only really for the most part when they were experiencing menstrual pain, and then they were given a demand like, make your bed or, right, do the dishes. So what they did in the study is they tried to address both those things, the pain as well as the demands, right? So, for example, for the pain element, one thing you could do then would be, to give Tylenol or give, what's the thing you give? Midol, when you're having menstrual cramps, right? I don't think they actually gave pills in the study. I think they just gave heating pads and other ways of reducing that individual's menstrual cramps. But, your first goal is to reduce the pain, obviously, clearly. But then the other things they did, too, is they provided a lot of non-contingent, what we call non-contingent access to reinforcement when the individual was in pain, right? So, for example, when one individual was having menstrual cramps, they knew she really enjoyed drinking hot tea. So before giving her any demands, like make your bed or, brush your teeth, they would give her some hot tea first to kind of think of it like a good mood inducer, to put her in a better mood and help her to be more relaxed and in less pain. So that's one thing they would do. They taught the individual to ask for breaks or to ask for help with these task demands, like help me make my bed, right? Or I want a break. They gave the individual choices over how to complete these tasks. They did what's called redistributing demands, where they said, you know, if the individual wasn't feeling well enough to, let's say, make their bed at that time, they would give them a choice of completing the task at a later time, completing it now or completing it in an hour, right? So again, it gives the individual some control over maybe not necessarily even their pain in that moment, but at least how they can cope with their pain or handle their pain, right? Because like sometimes when we're in pain, we can't necessarily do anything to reduce it, but we know we just want to lay down or drink tea or certainly not make our bed at that moment, right? So at least it helps to give the individual some control over that, right? So it was a multi-component intervention that incorporated all of these different things. And so I think that's often going to be what is your best bet in some way, thinking about how can we look for the individual. You know, sometimes you can also look for the nonverbal indicators of pain, which is something they did in this study too, and something I do clinically with kids, like what are the things that indicate pain? Okay, are they holding their stomach? That might indicate stomach pain. Are they crying or moaning or groaning in some way? Are they trying to lie down a lot, right? It might be that you know your kid's more likely to be in pain when they're trying to lay down on the bed or couch a lot. You know, maybe they're not saying hurt or sick or pain or anything of that sort, but you might be able to rely on nonverbal indicators. And what you could do is I've seen this happen a lot with parents and teachers or parents and staff. Let's say you as a parent are able to recognize those nonverbal indicators of pain better. You could have a checklist every day where you kind of send in, you know, to the teachers saying, are these behaviors present or not, like holding their stomach or holding their ear or doing something of that sort. And then if that's the case, that's when they might want to, again, provide some sort of good mood inducer before a demand or redistribute demands, like say, do you want to do it now or later? So it helps the individual. It could help teachers or staff or other people sort of know the different things to look for. Because again, you might know your kid better and know the certain things they might do when they're in pain. I hope that helps answer the question a little bit. But again, you know, the medical doctor obviously is the person who's the best one to assess whether there are some GI problems, which are some of the most common symptoms of pain are irritable bowel syndrome or reflux or GI symptoms are probably some of the most common things. But also, again, headaches, ear infections, all of those other things. It can be particularly difficult to figure out in someone who's not speaking if they're not indicating any sort of nonverbal indicators of pain, but especially if you notice a sudden change in someone's behavior or you notice it's more likely to happen, like I said, when there's no demands going on, like if you notice they're self-injuring or they're, you know, being aggressive when there's nothing else going on, there's no demands being placed on them, let's say they're just sitting there watching TV, but they're banging their heads, and you're not responding by turning off the TV, for example. You know, if there's no clear consequences of something being removed or added in response to their self-injury, that gives you a good sense that really there could be something medical going on.